Biochemistry, nutrition, essential fatty acids. Essential fatty acids are polyunsaturated fatty acids that cannot be synthesized in the human body and must therefore be obtained from the diet. They are found in foods such as nuts, seeds, plant oils, and seafood. Linoleic acid, which is an omega-6 fatty acid, is metabolized into arachidonic acid. Arachidonic acid is important because it serves as the precursor for the synthesis of leukotrienes and prostaglandins. Linolenic acid, which is an omega-3 fatty acid, and its metabolites provide cardioprotective and anti-hyperlipidemic benefits. In contrast, consumption of trans-unsaturated fatty acids, such as those commonly found in fast foods, contributes to cardiovascular disease. This occurs because trans fats increase low-density lipoprotein, or LDL, and at the same time decrease high-density lipoprotein, or HDL. Fat-soluble vitamins. The fat-soluble vitamins are vitamins A, D, E, and K. Their absorption depends on bioemulsification, pancreatic secretions, and an intact ileum. Toxicity from fat-soluble vitamins is more common than toxicity from water-soluble vitamins because fat-soluble vitamins accumulate in body fat. Malabsorption syndromes that cause steatorrhea, such as cystic fibrosis or celiac disease, as well as ingestion of mineral oil, can lead to deficiencies of fat-soluble vitamins. Water-soluble vitamins. The water-soluble vitamins include vitamin B1, also called thiamine, which is required for thiamine pyrophosphate or TPP. Vitamin B2, also called riboflavin, which is required for flavin adenine dinucleotide or FAD and flavin mononucleotide or FMN. Vitamin B3, also called niacin, which is required for nicotinamide adenine dinucleotide or NAD. Vitamin B5, also called pantothenic acid, which is required for coenzyme A. Vitamin B6, also called pyridoxine, which is required for pyridoxal phosphate or PLP. Vitamin B7, also called biotin. Vitamin B9, also called folate. Vitamin B12, also called cobalamin. And vitamin C, also called ascorbic acid. Water-soluble vitamins are washed out easily from the body, with the exceptions of vitamin B12 and vitamin B9. Vitamin B12 is stored in the liver for approximately 3 to 4 years, while vitamin B9 is stored in the liver for about 3 to 4 months. Deficiency of B-complex vitamins often results in dermatitis, glossitis, and diarrhea. Water-soluble vitamins can act as coenzymes, such as ascorbic acid, or as precursors to coenzymes, such as FAD and NAD. Dietary supplementation needs. Specific diets may require vitamin supplementation. Vegetarians and vegans need supplementation with vitamin B12 and iron, and they often also require vitamin B2. Vitamin D supplementation is frequently necessary, not only in vegetarian diets, but also in many other diets, since vitamin D deficiency is common. A diet high in raw egg whites requires vitamin B7 supplementation because avidin, a protein found in egg whites, binds biotin and prevents its absorption. Diets based on untreated corn may lead to vitamin B9 deficiency, which is common in resource-limited areas. Vitamin A. Vitamin A includes retinol, and retinoic acid. Its functions include acting as an antioxidant, serving as a constituent of visual pigments such as retinol, and being essential for the normal differentiation of epithelial cells into specialized tissues such as pancreatic cells and mucus-secreting cells. It helps prevent squamous metaplasia. Retinol itself is vitamin A, so the name Retin A is a helpful reminder, as Retin A is used topically for wrinkles and acne. Vitamin A is found in sources such as liver and leafy vegetables. Supplementation in patients with measles who are vitamin A deficient may improve outcomes. Oral isotretinoin, a derivative of vitamin A, is used to treat severe cystic acne, while all-trans-retinoic acid is used to treat acute promyelocytic leukemia. Deficiency of vitamin A leads to several problems, including night blindness, which is also known as nyctalopia, dry, scaly skin, also known as xerosis cutis, dry eyes, also known as xerophthalmia, and conjunctival squamous metaplasia that leads to the formation of Bitot spots, which are keratin debris that appear as foamy patches on the conjunctiva. Severe deficiency may also cause corneal degeneration or keratomalacia, as well as immunosuppression. Excess vitamin A can cause acute or chronic toxicity. Acute toxicity presents with nausea, vomiting, and increased intracranial pressure, which can manifest as vertigo and blurred vision. Chronic toxicity presents with alopecia, dry and scaly skin, hepatic toxicity and enlargement, joint pain or arthralgias, and idiopathic intracranial hypertension. Vitamin A derivatives such as isotretinoin are teratogenic because they interfere with homeobox genes, leading to congenital abnormalities such as cleft palate and cardiac malformations. For this reason, before prescribing isotretinoin, a pregnancy test and 2 reliable forms of contraception are required. Isotretinoin is teratogenic. Vitamin B1 thiamine. Vitamin B1, also called thiamine, functions as thiamine pyrophosphate, abbreviated as TPP, which is a cofactor for several dehydrogenase enzyme reactions. These enzymes can be remembered by the mnemonic BAPT, which stands for branched-chain ketoacid dehydrogenase, alpha-ketoglutarate dehydrogenase from the TCA cycle, pyruvate dehydrogenase, which links glycolysis to the TCA cycle, and transketolase, which functions in the HMP shunt. Deficiency of vitamin B1 results in impaired glucose breakdown, leading to ADP depletion. The depletion is worsened by glucose infusion, and highly aerobic tissues, such as the brain and heart, are affected first. In patients with chronic alcohol overuse or malnutrition, it is crucial to give thiamine before giving dextrose to reduce the risk of precipitating Wernicke encephalopathy. The diagnosis of vitamin B1 deficiency can be made by demonstrating an increase in red blood cell transketolase activity following thiamine administration. Several disorders are associated with thiamine deficiency. Wernicke encephalopathy is an acute, reversible, and life-threatening neurological condition. It is characterized by confusion, ophthalmoplegia with nystagmus, and ataxia. These 3 features can be remembered with a mnemonic Corona beer, where COR stands for confusion, O, and N for ophthalmoplegia and nystagmus, and A for ataxia. Korsakoff syndrome is an amnestic disorder that occurs due to chronic alcohol overuse and presents with confabulation, personality changes, and memory loss, which is typically permanent. Wernicke-Korsakoff syndrome results from damage to the medial dorsal nucleus of the thalamus and the mammillary bodies and presents as a combination of the symptoms of Wernicke encephalopathy and Korsakoff syndrome. Other consequences of vitamin B1 deficiency include dry beriberi, which is characterized by polyneuropathy and symmetric muscle wasting. A memory trick is to spell beriberi as burl to recall its association with vitamin B1. Wet beriberi is another manifestation and is associated with high-output cardiac failure due to systemic vasodilation. Vitamin B2, riboflavin. Vitamin B2 is also called riboflavin. Its main function is that it serves as a component of flavins, namely flavin adenine dinucleotide, FAD, and flavin mononucleotide, FMN. These act as cofactors in important redox reactions, such as the succinate dehydrogenase reaction in the tricarboxylic acid cycle. A helpful way to remember this is that FAD and FMN are derived from riboflavin, and vitamin B2 is associated with the production of approximately 2 ADP molecules. Deficiency of vitamin B2 results in several characteristic findings. Chylosis occurs, which is inflammation of the lips along with scaling and fissures at the corners of the mouth. A magenta-colored tongue may be present, and corneal vascularization can also develop. These deficiency signs can be remembered as the 2Cs of vitamin B2, chylosis and corneal vascularization. Vitamin B3, niacin or nicotinic acid. Vitamin B3 is also called niacin or nicotinic acid. Its function is that it serves as a constituent of nicotinamide adenine dinucleotide, NAD, and nicotinamide adenine dinucleotide phosphate, NADP. These molecules are essential cofactors used in redox reactions and are required by many dehydrogenase enzymes. Vitamin B3 is derived from the amino acid tryptophan, and its synthesis requires vitamin B2 and vitamin B6. Niacin is also used clinically to treat dyslipidemia because it decreases very low-density lipoprotein, also called VLDL, and increases high-density lipoprotein, also called HDL. A useful mnemonic is that NAD is derived from niacin, and vitamin B3 corresponds to approximately 3 ADP molecules. Deficiency of vitamin B3 first presents with glossitis. Severe deficiency leads to pellagra, a syndrome that can also be caused by other conditions such as Hartnup disease, malignant carcinoid syndrome, which increases tryptophan metabolism and decreases serotonin synthesis, and isoniazid therapy, which decreases vitamin B6. Pellagra is remembered by the 3Ds: diarrhea, dementia, which may also include hallucinations, and dermatitis. The dermatitis presents as a circumferential broad collar rash along the C3 and C4 dermatomes, also called the Casal necklace, with hyperpigmentation of sun-exposed limbs. Hartnup disease is an autosomal recessive condition that leads to deficiency of neutral amino acid transporters in the proximal renal tubular cells and on enterocytes. This results in neutral amino aciduria and decreased absorption of neutral amino acids from the gut, leading to decreased availability of tryptophan for conversion into niacin. As a result, the patient develops pellagra-like symptoms. The treatment is a high-protein diet along with nicotinic acid supplementation. To recall pellagra, remember that when vitamin B3 levels fell, pellagra results. Excess vitamin B3 causes flushing of the face, which is induced by prostaglandins rather than histamine. This flushing can be prevented by taking aspirin before niacin administration. Other consequences of excess vitamin B3 include pruritus, hyperglycemia, and hyperuricemia. To recall niacin overdose, remember podagra, which refers to gout-like symptoms associated with excess vitamin B3. Vitamin B5, pantothenic acid. Vitamin B5 is also called pantothenic acid, which can be remembered with the phrase B5 is pantothenic acid. The function of vitamin B5 is that it serves as a component of coenzyme A, which acts as a cofactor for acyl transfers, and it is also a component of fatty acid synthase. Deficiency of vitamin B5 leads to dermatitis, enteritis, alopecia, and adrenal insufficiency. It may also cause a burning sensation of the feet, which is sometimes referred to as burning feet syndrome, and is characterized by distal paresthesias and dysesthesia. Vitamin B6, pyridoxine. Vitamin B6 is also called pyridoxine. It is converted in the body to pyridoxal phosphate, also known as PLP, which serves as a cofactor in a wide range of important biochemical reactions. These include transamination reactions, such as those catalyzed by alanine aminotransferase, LT, and aspartate aminotransferase, AST, decarboxylation reactions, and the activity of glycogen phosphorylase. Vitamin B6 is also required for the synthesis of glutathione, cystathionine, heme, niacin, histamine, and several neurotransmitters including serotonin, epinephrine, norepinephrine, dopamine, and gamma-aminobutyric acid, also called GABA. Deficiency of vitamin B6 results in convulsions, hyperirritability, peripheral neuropathy, which can be induced by isoniazid therapy or oral contraceptive use, and sideroblastic anemia, which arises from impaired hemoglobin synthesis and excess iron accumulation. Vitamin B7 biotin. Vitamin B7 is also called biotin. It serves as a cofactor for carboxylation enzymes, which function by adding a 1-carbon group. These enzymes include pyruvate carboxylase, which catalyzes the reaction of pyruvate, a 3-carbon compound, into oxaloacetate, a 4-carbon compound, during gluconeogenesis. Acetylcoenzyme A carboxylase, which catalyzes the conversion of acetylcoenzyme A, a 2-carbon compound, into malonyl-coenzyme A, a 3-carbon compound, during fatty acid synthesis. Propional coenzyme A carboxylase, which catalyzes the conversion of propional coenzyme A, a 3-carbon compound, into methylmalonyl coenzyme A, a 4-carbon compound, during fatty acid oxidation and the breakdown of branched-chain amino acids. Deficiency of vitamin B7 is relatively rare, but may present with dermatitis, enteritis, and alopecia. Causes of deficiency include long-term antibiotic use or excessive ingestion of raw egg whites, since avidin found in egg whites avidly binds biotin and prevents its absorption. Vitamin B9 folate. Vitamin B9 is also called folate. It is converted into tetrahydrofolic acid, or THF, which is a coenzyme for 1-carbon transfer and methylation reactions. Folate is critically important for the synthesis of nitrogenous bases in both DNA and RNA. Dietary folate is abundant in leafy green vegetables and is also produced by gut microbiota. Absorption occurs primarily in the jejunum, which can be remembered with the phrase foliage in the jejungle. Folate has only a small reserve pool, which is stored mainly in the liver. Deficiency of vitamin B9 leads to macrocytic, megaloblastic anemia, hypersegmented polymorphin nuclear neutrophils, and glossitis. Unlike vitamin B12 deficiency, vitamin B9 deficiency does not cause neurologic symptoms. Laboratory findings include elevated homocysteine levels with normal methylmalonic acid levels. Deficiency is commonly seen in patients with chronic alcohol overuse and in pregnancy. Causes of vitamin B9 deficiency include the use of certain drugs such as phenytoin, trimethoprim, and methotrexate. Supplemental folic acid should be given at least 1 month prior to conception and throughout pregnancy to decrease the risk of neural tube defects. A helpful way to remember this is to give vitamin B9 for the 9 months of pregnancy, and also beginning at least 1 month before conception. Vitamin B12, also called cobalamin, functions as a cofactor for 2 key enzymes: methionine synthase, which transfers methyl groups in the form of methylcobalamin, and methylmalonyl, coenzyme A mutase. Both reactions are critically important for DNA synthesis and normal metabolism. Vitamin B12 is found only in animal products. Although it is synthesized by intestinal microbiota, the site of synthesis in humans lies distal to the site of absorption, which is the terminal ileum. Therefore, humans cannot rely on intestinal production and must obtain vitamin B12 from dietary animal sources. Deficiency of vitamin B12 leads to macrocytic, megaloblastic anemia, The presence of hypersegmented polymorphonuclear neutrophils, paresthesias, and subacute combined degeneration. Subacute combined degeneration refers to the degeneration of the dorsal columns, lateral corticospinal tracts, and spinocerebellar tracts of the spinal cord, caused by abnormal myelin. This manifests as impaired proprioception, vibratory sense, spasticity, and ataxia. Laboratory findings include elevated serum homocysteine and elevated methylmalonic acid levels. Secondary folate deficiency may also occur. A key clinical point is that prolonged vitamin B12 deficiency can cause irreversible nerve damage if not corrected. Vitamin B12 has a very large reserve pool that can last several years, stored primarily in the liver. Causes of deficiency include malabsorption, such as in celiac sprue, enteritis, infection with the fish tapeworm Diphyllobothrium latum, achlorhydria, bacterial overgrowth, and chronic alcohol overuse. Deficiency can also result from lack of intrinsic factor, as seen in pernicious anemia or after gastric bypass surgery, from absence of the terminal ileum, for example after surgical resection in Crohn's disease, from medications such as metformin, or from insufficient intake, such as in strict veganism. An important point is that folate supplementation with vitamin B9 can mask the hematologic symptoms of vitamin B12 deficiency, meaning the anemia may improve, but the neurological symptoms will persist and continue to progress. Vitamin C, ascorbic acid. Vitamin C, also called ascorbic acid, serves as a powerful antioxidant and facilitates iron absorption by reducing it from the ferric, Fe superscript 3, state to the ferrous, Fe superscript 2 state. Vitamin C is necessary for the hydroxylation of proline and lysine residues during collagen synthesis and for dopamine beta-hydroxylase, which converts dopamine into norepinephrine. Dietary sources of vitamin C include fruits and vegetables. A useful memory aid is to think of ascorbic acid as absorbic acid, since it helps with iron absorption. Vitamin C also serves as an ancillary treatment for methemoglobinemia, as it helps reduce iron from the ferric, Fe superscript 3, to the ferrous, Fe superscript 2, state, restoring hemoglobin's ability to bind oxygen. Deficiency of vitamin C causes scurvy, which presents with swollen gums, easy bruising, petechiae, hemarthrosis, anemia, poor wound healing, parafollicular and subperiosteal hemorrhages, and corkscrew hair. The weakened connective tissue is due to defective collagen hydroxylation. Patients may also experience impaired immunity. Deficiency is sometimes seen in patients with very poor diets, such as the so-called tea and toast diet. A way to remember this is that vitamin C deficiency leads to scurvy due to a collagen hydroxylation defect. Excess vitamin C intake can cause nausea, vomiting, diarrhea, and fatigue. It can also lead to calcium oxalate nephrolithiasis due to excess oxalate produced during vitamin C metabolism. Additionally, very high vitamin C intake can increase dietary iron absorption, leading to iron overload in predisposed individuals, such as those with hemochromatosis or transfusion-related iron overload. Vitamin D. Vitamin D exists in two main dietary and endogenous forms. Vitamin D3, also called cholecalciferol, is derived from the exposure of skin, specifically the stratum bile, to sunlight, and can also be obtained through ingestion of fish, milk, and plants. Vitamin D2, also called ergocalciferol, comes from ingestion of plants, fungi, and yeasts. Both vitamin D2 and vitamin D3 are converted in the liver to 25-hydroxy vitamin D3, which is the storage form, and then further converted in the kidney to the active form 1,25-dihydroxy vitamin D3, also called calcitriol. Functions: vitamin D increases intestinal absorption of calcium and phosphate. At low levels, It promotes bone mineralization, while at higher levels, it stimulates bone resorption. Regulation. Parathyroid hormone, low calcium, and low phosphate all stimulate production of 1,25-dihydroxyvitamin D3. Active vitamin D feeds back to inhibit its own production. Parathyroid hormone increases calcium reabsorption in the kidney, but decreases phosphate reabsorption in the kidney. Deficiency. In children, deficiency causes rickets, which presents with skeletal deformities such as genu varum or bow legs. In adults, deficiency causes osteomalacia, presenting as bone pain and muscle weakness, and it can also cause hypocalcemic tetany. Causes include malabsorption, inadequate sunlight exposure, poor diet, chronic kidney disease, and advanced liver disease. Breastfed infants should receive oral vitamin D supplementation because human breast milk alone is not sufficient. Darker skin pigmentation and prematurity are additional risk factors for deficiency. Excess vitamin D can lead to hypercalcemia, hypercalciuria, loss of appetite, and stupor. It can be seen in granulomatous diseases, where epithelioid macrophages activate vitamin D inappropriately. Vitamin E. Vitamin E includes tocopherols and tocotrienols. Function. It acts as an antioxidant that protects red blood cells and neuronal membranes from free radical damage. Deficiency. Vitamin E deficiency results in hemolytic anemia, acanthocytosis, muscle weakness, and demyelination of the posterior columns, which impairs proprioception and vibratory sensation, as well as demyelination of the spinocerebellar tracts, which causes ataxia. This presentation closely mimics Friedreich ataxia. The neurologic findings may also resemble vitamin B12 deficiency. However, vitamin E deficiency does not cause megaloblastic anemia, does not cause hypersegmented neutrophils, and does not cause elevated serum methylmalonic acid levels. Excess vitamin E intake poses a risk of enterocolitis in infants. High-dose supplementation may interfere with the metabolism of vitamin K-dependent proteins, including clotting factors 2, 7, 9, and X, as well as protein C and protein S. This can enhance the anticoagulant effects of warfarin. Vitamin K. Vitamin K includes phytomenadian, phylloquinone, phytonadian, and menaquinone. It is activated by epoxide reductase into its reduced form, which serves as a cofactor for the gamma carboxylation of glutamic acid residues on various proteins that are required for blood clotting. Vitamin K is synthesized by intestinal microbiota, and dietary sources include leafy green vegetables. A helpful way to remember its function is that K stands for coagulation. Vitamin K is necessary for the maturation of clotting factors 2, 7, 9, and 10, as well as protein C and S. Warfarin works by inhibiting the vitamin K-dependent synthesis of these clotting factors and proteins. Deficiency. Vitamin K deficiency presents as neonatal hemorrhage with an increase in prothrombin time and an increase in activated partial thromboplastin time, but with a normal bleeding time. This occurs because neonates have sterile intestines and are therefore unable to synthesize vitamin K. Deficiency can also occur after prolonged use of broad-spectrum antibiotics or in the setting of hepatocellular disease. Vitamin K is not found in breast milk, which is why the mnemonic says, breastfed infants don't know about vitamins D and K. To prevent hemorrhagic disease of the newborn, all neonates are given a vitamin K injection at birth. Zinc. Zinc is a mineral that is essential for the activity of more than 100 enzymes. It is also important in the formation of zinc fingers, which are transcription factor motifs. Deficiency. Zinc deficiency causes delayed wound healing, suppressed immunity, male hypogonadism, decreased adult hair growth, including axillary, facial, and pubic hair, dysgeusia, which is impaired taste, and anosmia, which is loss of smell. Zinc deficiency is associated with acrodermatitis enteropathica, a congenital defect in intestinal zinc absorption that presents with a triad of hair loss, diarrhea, and an inflammatory skin rash located around body openings, also called periorificial regions, and at the tips of fingers and toes, which are called acroregions. Zinc deficiency may also predispose to alcoholic cirrhosis. Protein energy malnutrition. Kwashiorkor. Kwashiorkor is a form of protein malnutrition that results in skin lesions and edema due to reduced plasma oncotic pressure, which arises from decreased serum albumin and decreased antidiuretic hormone. It also causes liver malfunction due to reduced apolipoprotein synthesis, leading to fatty liver deposition. The classic clinical picture is a small child with a swollen abdomen. A helpful mnemonic is that kwashiorkor results from protein-deficient meals, where M stands for malnutrition, E for edema, A for anemia, L for liver fatty change, and S for skin lesions such as hyperkeratosis and dyspigmentation. Marasmus. Marasmus is malnutrition that does not cause edema. It results from a diet deficient in calories, but no single nutrient is entirely absent. Marasmus leads to muscle wasting. In acute protein energy malnutrition, linear growth is maintained, in contrast to chronic malnutrition. Ethanol metabolism. An increased ratio of NADH to NAD inhibits the tricarboxylic acid cycle because increased acetyl-CoA is used in ketogenesis, which leads to ketoacidosis, and in lipogenesis, which leads to hepatosteatosis. Females are more susceptible than males to the effects of alcohol due to decreased activity of gastric alcohol dehydrogenase, decreased body size, and decreased percentage of water in body weight. Nicotinamide adenine dinucleotide, abbreviated as NAD, is the limiting reagent. Alcohol dehydrogenase operates via zero-order kinetics. Ethanol metabolism causes an increased NADH to NAD ratio in the liver, resulting in the following. 1. Lactic acidosis due to increased pyruvate conversion to lactate. 2. Fasting hypoglycemia due to decreased gluconeogenesis from decreased conversion of oxaloacetate to malate. 3. Ketoacidosis due to diversion of acetyl-CoA into ketogenesis rather than the tricarboxylic acid cycle. 4. Hepatosteatosis due to increased conversion of dihydroxyacetone phosphate to glycerol 3-phosphate. Acetyl-CoA diverges into fatty acid synthesis, which combines with glycerol 3-phosphate to synthesize triglycerides. Fomepizole is a competitive inhibitor of alcohol dehydrogenase and is the preferred antidote for overdoses of methanol or ethylene glycol. Alcohol dehydrogenase has higher affinity for ethanol than for methanol or ethylene glycol. Ethanol can therefore be used as a competitive inhibitor of alcohol dehydrogenase to treat methanol or ethylene glycol poisoning. Disulfiram blocks acetaldehyde dehydrogenase, leading to increased acetaldehyde, increased hangover symptoms, and discouraging drinking.